better strategies going forward. It provided us with a very a realistic example of a bus stop. I think we all understood just from that simple example. So let's move on to the IP. Now we've heard from the donor, Dr. Afke. So, Dr. Afke, could you just discuss, tell us the highlights of the role of IP in supporting the national efforts that we just heard about through implementation of various innovative interventions and to address the issues affecting adolescents, youth with HIV. Karibu.
Thank you, Dr. Ndama, and good afternoon to everybody. I think the role of most implementers or stakeholders in this space is quite clear and straightforward. Our main role is to complement government efforts towards epidemic control. And we can do this through many ways, including we are seeing are working in the different programs that are being implemented in the country. I would like to emphasize on this using a story. Let's, for the purpose of this discussion, let's call her Amy, who is an AGY from the Southern Highlands. So Amy grew up in quite in the rural areas where her parents, due to economic hardships, put her under the custody of the grandparents, the uncle. And this was because the grandparents were too elderly to take her in at the time. Now, under this guardianship, now this uncle is not necessarily a blood relative. We understand in most of our cultures, any relative who is familiar to the family, we commonly refer to them as uncles. Now, one of the unique features about Amy's story is that while she was there, she experienced and witnessed a lot of physical violence coming from the uncle, and this prompted her actually to move outside the household, to come to the urban area to seek for a better life. Now, of course, while in the urban areas, she met up with a male partner that she thought at the time she was very much in love with and she could start a life with. However, the cycle continued, the cycle of GBV, and Amy one time visited a health facility as a result of this GBV. This is where Amy met with a peer from the DREAMS program who recruited her into the program, and she started undergoing sessions, learning about GBV, about HIV testing, and other services that are available within her local community. Why is Amy's story important? Because Amy's story reflects the reality of most of the AGY who are at substantial risk for new HIV infections, particularly in the Southern Highlands, and the impact of her interaction with a peer had in her life and how it was able to transform her story from coming from an impoverished place to one where she feels empowered and one where she understands how best she can take effective steps to not only protect herself, but also ensure that she lives a happy and fulfilled life. So the main theme here we're discussing is adolescents, youth, and HIV, and what are some of the innovative initiatives and strategies that we think are effective. In my opinion, I believe it's important to look at what are the ways in which we can engage the youth and what tools are currently available or we can think of in the future. One of them, I think, which we have probably heard in a lot of forums, is the use of technology. As we understand, a lot of education has been done, or a lot of sensitization has been done on HIV/AIDS, what is HIV, modes of transmission. However, we appreciate that the youth nowadays consume this information probably a bit differently from the way it was disseminated 10, 20 years ago. So the information that is being targeted and segmented to the youth nowadays has to be tailor-made to suit how the current target beneficiaries are actually consuming it. So use of telehealth is one of the options in which IPs are actually complementing this effort by providing a service that is stigma-free, that is accessible to a much wider youth, that is easy, provides confidentiality and privacy, which is a major concern for most of the youth. Youth will share concerns and fears of accessing HIV testing services or repeat interaction with the health facility based on concerns of stigma or discrimination, whether real or perceived. On the other hand, we know that tailor-made and education to these services. We know there are technologies that provide chatbot services, that provide HIV self-testing to this youth, and it's something that is easy to use. It's very discreet of urban and peri-urban setting. Additionally, as I've highlighted from Amy's story, is the need to emphasize on peer-to-peer approaches. We understand that, and we know from evidence that peer-to-peer approaches work, and they are working. It's easier to listen to somebody's lived-in experience that is very similar to you, and they look like you. Meaning that when I listen to my fellow peer and they're telling me about something that concerns me, concerns my health, I'm most likely to respond positively to them than hearing it from somebody. And you'll hear this narrative a lot when it comes to conversations between youth and people of other generations that, during your time, things were different. Nowadays, we're living in a different era. Hence come the tug of war between millennials, baby boomers, and Gen Zs. We'll leave that for another topic. But also engaging youth on multiple platforms, including social media. A lot of us are connected to the net, and so are the youth. They consume a lot of the information that we typically expect either for them to access through the health facilities, through print media, but most of the time this information comes from social media, either through influencers or other different educational platforms. So this presents a golden opportunity for us to actually leverage those platforms to educate the youth. I think just to another way or initiative that works, and IPs as HJFMRI we're implementing, is through comprehensive sexuality education. And this includes life skills training to empower the youth to make informed choices about their health, but also, very importantly, about their relationships. When I say no, how do I then say no that my partner understands is a no? What does a yes look like? How do I negotiate, for example, condom use within a relationship? How do I initiate the topic of contraception use in my new relationship? These are topics, or these are topics that are very important, especially for the youth nowadays. However, they require support or to learn these skills of how to introduce these topics. Sometimes it doesn't necessarily need to come from first-hand experience. It can come from being having a conversation with a peer, having conversation with a friendly provider who provides these services in a non-stigmatizing way, in a way that makes them feel safe and accommodated in their needs. Additionally, I believe it's very important to engage the community when you are discussing youth, both the wider community where most of these youth live, so that they understand also the importance of supporting youth accessing these services from different places, including the health facility, but also engaging the community of beneficiaries themselves, meaning the youth. I want to echo what all the other panelists have been saying from the beginning. A few years ago, they started a trend of nothing for us without us. I think the same needs to be said about youth. And here, particularly, engaging them not just in listening into their views, but making sure those views are reflected in the policies, in the interventions, in the programs that we are designing. It's very easy to listen to somebody and then say, okay, but you know, national policy doesn't support what you're proposing. I believe just like when you're going into the market, Dr. Alec has given a very good analogy of the road. The road is constructed based on a need, and the bus stops are put there because that's where most people want to alight. Therefore, it's a good opportunity for us as well to see if we can actually break this mold of saying the policy doesn't support what you're proposing. However, can the policy be to accommodate the views of youth? It's actually heard, and it's reflected in the intervention, in the policies. And lastly, of course, is the issue of research data on whether these interventions are being effective and the best way to, but also issues of mental health. We have discussed a lot about some of the predisposing factors that put youth at substantial risk for new HIV infections, but also that preclude them from viral suppression per se. And I think mental health is an upcoming topic that we need to start having a wider conversation about. How do we support youth in their mental health? I think one of the best practices we have from the DREAMS program is how the AGY in their groups are able to form social capital. They are able to have groups where they feel safe, where they feel accommodated, where they feel that their voices are being heard, but where they receive tailor-made information that is easy for them to consume, but also easy for them to ask questions and clarification on. But last but not least, also I think it's important to explore new ways of engaging through media or any other platform that youth resonate with in the current era that we're living in. Thank you so much.
Thank you very much, Dr. Afke. A proper round of applause for her, please. Yes. So last but not least, we have heard from all levels. So let us now engage the beneficiary, Janet. So Janet, naomba tuzungumze labda ni jinsi gani vijana mnahusishwa kwenye mapambano dhidi ya virusi vya ukimwi na ukimwi, na ni changamoto gani ambazo mnazipitia kwenye mapambano hayo. Karibu sana. So I've just asked Janet to discuss with us, just provide insights of how they are engaged, the youth in general are engaged in joining the response and could contribute towards epidemic control. Karibu sana.
Asante. Kwa majina yangu naitwa Janet Fred Mwakitega. Natokea Mbeya. Natokea katika shirika la Tumaini, mradi wa DREAMS. Mradi unahusika na mabinti wenye umri wa miaka 15 hadi 24. Lengo la mradi wetu ni kupunguza maambukizi ya virusi vya ukimwi kwa vijana wenye umri wa miaka 15 hadi 24. Swali langu nimeulizwa tunahusishwa vipi sisi kama vijana kwenye mapambano ya virusi vya ukimwi. Uhusishwaji wetu sisi ni mkubwa sana kwa sababu njia na tabia hatarishi. Lakini pia tunahusishwa vizuri kwa sababu kwenye shirika letu tunafanya kazi na watu wa peer educator. Peer educator ni watu ambao wanakuwa karibu na wale AGY. Obviously muda mwingi wanakuwa na AGY kwa ajili ya kutoa elimu, lakini pia tuna watu ambao tunawaita mentors, washauri wa wale mabinti. Pia nao wanahusishwa kwenda kutoa elimu kwa wale wasichana, elimu mbalimbali ambazo zinahusiana na maambukizi ya virusi vya ukimwi na jinsi ya kupambana na hayo maambukizi ya virusi vya ukimwi. Elimu hizo nimesema hapo mwanzo ni kama elimu za mabadiliko ya kitabia, elimu za upimaji, elimu za kuinuana kiuchumi. Kwenye swala la upimaji, tunapomuunda binti kwenye kikundi lazima tumfanyie testing. Tukipima binti tukikuta yuko negative, basi yuko kwenye high risk ya kupata maambukizi ya virusi vya ukimwi, tunamuunganisha kwenye kituo cha afya kwa lengo la kupata huduma ya dawa kinga PrEP. Lakini pia tukikuta kijana niko positive, tunamuunganisha kituo cha afya kwa ajili ya kutumia ARV. Na hatuishii hapo kwenye kumuunganisha, tunafanya ufuatiliaji kwamba huyu kijana tumemuunganisha kituo cha afya kwa ajili ya kutumia ARV. Je, maendeleo yake ni yapi? Anahudhuria kliniki? Anafuata masharti yote anayopewa na daktari? Lakini pia kwenye swala zima la changamoto ambazo tunazipitia kwa sasa, changamoto sio nyingi kwa sababu tunashukuru wafadhili wetu wakishirikiana na serikali yetu ya Jamhuri ya Muungano wa Tanzania wameweza kutuempower kwa kiwango kikubwa sana na kuinvest kwetu sisi wasichana. Kwa hiyo changamoto tunazozipitia kwa sasa sio kubwa sana, nyingi zimeshafanywa utatuzi. Kwa hiyo changamoto zipo lakini sio kubwa sana kivile kwamba zinaweza zikamkwamisha binti kufikia malengo yake. Ambazo tunapitia naweza nikasema hasa nikazungumzia kwa wasichana wanaoishi na maambukizi ya virusi vya ukimwi. Changamoto tunazozipitia wasichana tunaoishi na maambukizi ya virusi vya ukimwi ni changamoto ya afya ya akili. Mabinti wengi na vijana wenye umri wetu wanaoishi na maambukizi ya virusi vya ukimwi wanapitia sana changamoto ya afya ya akili. Lakini tunashukuru hapo juzi kati tulikopo na kongamano la vijana, yani niseme tulikuwa na section ya binti jasiri ambayo ilifanyika Mbeya. Tulipata elimu vizuri kuhusiana na afya akili. Miongoni mwetu si wenyewe kuna baadhi ya maambasada ambao walitoka kwenda kuwafundisha wenzetu kuhusu swala la afya akili, lakini pia kuna watu ambao wapo wanahusika na sisi mabinti na vijana kwa ajili ya kutupatia elimu ya afya akili. Lakini changamoto nyingine tunayopitia ni mawasiliano duni kwa wasichana na vijana wanaoishi na maambukizi ya virusi vya ukimwi. Mawasiliano duni ya wao na familia zao imekuwa ni changamoto ya msichana. Kwa mfano msichana mwenye umri wa miaka 15 hadi 19, wengi wao wanakuwa wapo chini ya wazazi. Utakuta msichana anaishi na mzazi, kumwelekeza anatumia dawa sawa, lakini kumwelekeza mzazi wake ile changamoto anayoipitia inakuwa ni changamoto, kwa sababu anaweza kawaza, let's say msichana amezaliwa yuko safe, ana maambukizi ya virusi vya ukimwi, akaja kupata maambukizi ya virusi vya ukimwi akiwa kwenye umri wetu wa ujana ule wa miaka 15 hadi 20, akaja kupata maambukizi kwenye umri huo. Mtoto anawaza, nitamfikia vipi mzazi ili hali mama anajua mimi nilizaliwa nikiwa salama, lakini leo nina maambukizi ya virusi vya ukimwi, nitaenda kumwambia nini yule mzazi anielewe? Hiyo changamoto inatupata sisi vijana. Kwa hiyo changamoto hiyo mimi nadhani tutaitatua kwa kuomba wazazi wetu wawe wanapewa semina, au si wenyewe vijana tupewe semina jinsi ya kukaa na mzazi kumuelekeza hali hiyo inayopitia. Kwa sababu msichana akiwa anapitia hali kama hiyo au kijana, inaweza ikampelekea kuwa na msongo wa mawazo ambapo anashindwa kuwa comfortable na atashindwa kufanya mambo yake vizuri. Changamoto nyingine ni mabadiliko ya kiutamaduni. Hapa naweza nikaongelea kwa mfano, tumekutana vijana kutoka sehemu mbalimbali, tumekaa. Tamaduni za mimi msichana ninayetokea Mbeya na msichana anayetokea Dar haziwezi zikafanana muda mwingine. Utakuta tumekaa tunapiga story sisi wasichana. Mimi wengine hawajui kwamba mimi nina maambukizi. Katika kupiga zile story, kwa mfano tupo kwenye mzozano. Kwa nini vijana hawaendi kupima? Kwa nini vijana wanapima wanajua hali zao lakini hawaendelei na huduma? Kwa mfano kijana mmoja akatoa kashfa. Kwa mimi mtu ambaye anaweza nikaichukulia kashfa, kumbe kwa wao watu wa Dar ni kitu ambacho ni kawaida. Hicho kitu kinaweza kikamwasili mtu yoyote ambaye yupo kwenye hali hiyo. Lakini kitu kingine ni kujihusisha na mahusiano. Sisi mabinti, kwa mfano mimi msichana anaishi na maambukizi ya virusi vya ukimwi. Mimi ni kijana, bado damu inachemka. Obviously nitahitaji kuwa na partner. Sasa unakuja na waza, mimi nina maambukizi ya virusi vya ukimwi, nahitaji kuwa na mwenza wangu. Je, nikipata huyo mpenzi nitamwambia nini? Au ni nani yuko tayari kuwa na mimi ninaishi na maambukizi ya virusi vya ukimwi? Hiyo ni changamoto ambayo tunaipitia sisi vijana na mabinti wenye umri wa miaka 15 hadi 24. Asante.
Asante sana Janet. So tumemsikia Janet, as she said, she's from Tumaini CSO, which is under they have a dreams program that's working with the 15 to 24-year-old youth, and they are fully engaged. As she said, she provided us with the structure of how the program is designed, from the community to peers and then to mentors who deliver the needed education in the community, and how they are linked to facilities. She also highlighted a few challenges here. As we heard, there's a poor communication between parents and children, and she proposed that we need to educate parents on being close and supportive to their children. And she also touched on the differences in traditions or culture between one area and the other, and she finished by discussing a bit about having multiple sexual partners. Thank you very much, Janet. Another round of applause for her. Asante sana. So we did our best to have adequate time for questions. Now that's the time for that, and we are going to have 5 questions in the beginning, and then they're going to take those questions and answer them, and then later on we'll follow up with more questions. So can I have, we have a mic to the audience, please? Thank you. So let's take 5. That's number 1. Number 2. These are 2 questions. Number 3. We have 3. Number 4. Can we have the last one? Can we have the 5th question, please? Okay, let's go ahead and start with these 4. Karibu.
Good afternoon. My name is Krista Frank. I'm from KSMC, a medical student. And I would like to ask Dr. Afke. Yeah. You mentioned the innovative interventions for HIV control, which are well said. I appreciate. But I would like to know, from your point of view, how telehealth intervention can reach youth who live in extremely rural areas. Thank you.
This was the second.
Jerome Justin, a medical student from St. Francis, but the vice chairperson to Ndotonjema Foundation, which is a youth-led organization. I will ask this to any of the panelists. Like, if we as the youth, we would wish to engage and take lead to the challenges that we are facing concerning youth and reproductive health, what will be your immediate recommendation? That will be like a cheat code to turn the whole thing down. Thank you.
Thank you very much. The 3rd question, sir, here.
Thank you. Thank you very much. My name is Dr. Erik van Praag. I am retired in Ununio, but I'm still advising on many health aspects to the ministry and to NGOs. My question is really to Prosper, but also to Janet, what your ideas are about the promotion of self-testing HIV for adolescents. Self-testing as being done something by you yourself, it may not be so easy, but facilitated self-testing with some you are happy, you are relaxed, waited by somebody. I was very impressed by Janet, by an ambassador who has the trust of the clients, who can find an environment, a room where you feel okay, not a health facility, because the adolescent won't feel okay there, and their relatives may see her there, but in an environment where you feel okay, and then she can facilitate HIV self-testing. We have done that a little bit with community health workers. We still have to learn a lot. We can't say that is really the end of the road, but this is something I would like to have your view on. Is this something to be considered? Because it could really help us to have a much higher testing rate among this risk group, as you so rightly pointed out, for adolescent out-of-school girl.
Thank you very much. Okay, we had a 4th question. Yes, over there.
Thank you very much for this opportunity, and also thank you, the panelists, for insightful knowledge. My name is Gary Germanus. I'm a medical student from University of Dodoma, and my question is that I'd like to understand. I had mostly on Bayer, but also my second question is that how can we as medical students engage in intervention done by the organizations? But also the last question is that I like to have some highlight on research opportunities which are country. Thank you.
MC student to Dr. Afke, and then Jerome said anybody could answer that, so I'll leave that to you.
But even beyond school, like off campus, there's this need that we can further collaborate on. So again, I think I would like to return the challenge back to you to help us or tell us what do you need from us and how can we support. Thank you.
All right, thank you very much. You want to add up on that? You want to take care of your question. Okay, go ahead.
Yeah, thank you very much. Again, I think we had 2 questions. One is was a general question on how to engage youth And I think the other one was the use of assisted HIV self-testing. One is on how to engage youth. I wish I had the answer, and I have to be honest, I don't know. And I think that's one of the reasons why we have this conversation right now. And I think for me it's paramount that the youth, you're provided with opportunity, and I think we do not need to have you and us conversation, but we need to have a joint conversation. Because I understand that one of the barriers is the ability of those who, you know, are in the position of leadership to listen and to respond to what the youth need. And I think we need to break that barrier. And therefore I would recommend that really this will be an ongoing conversation on how we can really engage the youth. And we'll be looking forward to your guidance and your cues. And I'm saying this because in the HIV response, historically, when I look on where we're coming from and where we are right now, for many of us who have experienced HIV in the past, first we started with a disease that had no cure. So it was associated with despair and death. And then there was treatment, but again, no cure. But this treatment was not easily accessible. It was very expensive for treatment. So we had the experience in our formative experience and motivation, whether intrinsic or extrinsic, for HIV prevention and treatment is based on that fear, that lived experience. But now we're in an era where HIV treatment, testing, and prevention is prepaid. Somebody is paying for that. And therefore the population does not have the similar experience that we have had experienced before. And I think this calls for us maybe to pause, look back and see this generation that we're calling youth, how do they experience this epidemic, and how we can have a meaningful conversation so that we can design and structure the way that we deliver our intervention that resonates with their experience and what they want to achieve with their lives. So yes, we talk about technology, but technology is just the means. I think also the content and the way that we design these interventions need to resonate with what the youth needs in terms of experience. So to your question, Dr. Eric Van Praag, my brother, is that yes, the current policy allows for both self and assisted self-testing. I think one of the limitations that we'd like to acknowledge is that HIV self-testing is limited to those aged 18 years and above. And I think we have an opportunity to push the agenda and change this policy, because we know that sexual exposure and other exposure to HIV infection does not know the age-bound barrier. And therefore the conversation will be on how we can relax these policies so that HIV self-testing can be accessible to everyone. So yes, we have self-test and assisted testing, but I think the conversation needs to go broader than that. Thank you.
Thank you very much. Over to the next one. No, I think all of them were covered. So I think we all heard the responses. Do we have any follow-up questions? The ones that asked the questions. You want to add on something, Dr. Alec?
Well, maybe I can just highlight. I think there was a question from Jerry, I think from Dodoma. You mentioned about the, the programs. Why is it only in Mbeya? Just wanted just to give you a quick history. I think 10 years ago, PEPFAR announced the start of implementing DREAMS program in 10 countries, which were mostly affected by HIV. And we are lucky that Tanzania was one of those countries. So President Obama announced that he's going to support these 10 countries with the DREAMS program. And not all the regions, they implement DREAMS. So the focus was more on the, was based on the prevalence of HIV infection. So if you mentioned about Mbeya is one of the regions with the high prevalence in this country. So you also have other regions that also implemented DREAMS, but also the reasons why those regions were selected is simply because of the high infection prevalence compared to other regions. But Currently, we have 14 councils which are implementing this, what we call the core dreams. But the good news that for the past 2-3 years, we now have what we call enabler dreams. It is a dream, like a mirror of what dreams is right now, which is now being scaled up to other regions. So for example, in Southern Highland, I think there was only Mbeya, but today I think even Katavi, Rukwa, Songwe, they also implement the dreams like what we call enabler dreams. So that has been taken into consideration, not only Southern Highland, but also other regions also implement enabler dreams. So it is something that has already been put in place, considering that it's not only few regions need to benefit from this program, but other regions also has already been reached for now. Thank you.
Thank you very much, Dr. Afke. So there was one for Janet. Janet, eleza tu kwa ufupi, unadhani matumizi ya self-test kama alivyouliza mwenzetu kwa mentors, peers, yatakuwa na changamoto yoyote kuwaelewesha watumiaji?
Hapana, self-testing haina changamoto kwa kuelezea watumiaji. Lakini kuna changamoto ambayo vijana wengi wakitumia self-test wanaipata. Ukiwa kwa mfano ni msichana mwenye, yani niseme msichana ambaye umwahi kuumwa magonjwa ya ngono yale sugu. Sometimes ukitumia self-test kupima, kile kipimo kinaonyesha una maambukizi. Lakini pia changamoto nyingine ambayo tunakutana kwenye self-test, kwa mfano hata mimi nimewahi nikuta, ukiwa unatumia dawa vizuri, ukipima kile kwa kutumia kile kipimo, kuna muda kinaonyesha hauna maambukizi. Kwa hiyo ni moja ya changamoto ambayo tunaikuta kwa kutumia self-test. Ipo, lakini haijawa kubwa hivyo, kwa sababu tunavotoa elimu kuhusiana na self-test, tunawaambia kwamba hichi ni kipimo cha awali. Kwa hiyo unaweza ukapima, ukikuta kwa mfano kimeleta positive, lazima uende kituo cha afya ukapime na kile kipimo kingine. Kwa mfano mimi nilivopima self-test nikakuta nina maambukizi, la kile kipimo kikaonyesha sina maambukizi. Kwa kuwa nilikopo na elimu, nilienda kituo cha afya, nikakutana na mtu wa huduma anayenihudumia, nikamuelekeza. Lakini nikapima tena kile kipimo, majibu yakaonyesha ni positive bado. Kwa sababu ukiwa unatumia dawa vizuri, ukipimia kile kinaonyesha, muda mwingine sio muda wote, kuna muda kinaonyesha kwamba huna maambukizi. Lakini kama nilivyosema, ukiwa
the response, sir? You did? Not okay. Okay. So do you want to? Okay. So she said there's no challenge using the HIV self-test in assisted mode, but there are other challenges. She denoted that sometimes the kit brings out the reactive results if a person has a very chronic STI, and she herself experienced a non-reactive result when she was suppressed after proper use of ART for a long time. So in both cases, they're advocating for, they're educating the people to also seek visit the facilities for conventional HIV tests, just to confirm what the results are. So Dr. Afke, do you want to add anything to the technical side of the these results probably?
Yeah, I think we know that, like you've said, somebody who is virally suppressed, anybody who is either who are previously undiagnosed or have never tested, that means they're unaware of the HIV testing status. But for individuals, including adolescents living with HIV, then we don't recommend them to use HIV self-tests. Yes.
All right, thank you very much. So can you hand over the mic to Dr. Elizabeth? And this is for me, probably to, we are nearly approaching the end of this forum. So what is your thought? What is your take in, you know, if the government allows the assisted use of HIV self-test? Do you think the people in Mbeya are going to understand more on how to use them, or do you think they're going to resist us? They just want the kits and go use them by themselves, or you think they're going to like it that way?
as Mbeya is concerned now, as we started with the DREAM program, we know that the community of Mbeya now is very positive on the use of self-testing, and we are going to make sure that by the use of ambassadors as well as mentors, we are going to encourage to provide more health education on the use of self-test. And Mbeya region is very positive on the use of self-test. You know that Mbeya region is a region where we have a lot of business as well as long truck drivers as well as mining. So we really want to make sure that everyone has to have the real important health education on the use of self-test, because healthcare workers are not enough, even the mentors are not going to be enough. So we should engage the community as well to make sure that all they have the little information on the use of self-test.
All right, thank you very much. Does anybody has a follow-up question based on the 4 questions that we had prior? You have another new question? Second one, we're going to take 3. 3, okay. So let's go ahead and start with Madam over there.
Good afternoon.
Afternoon.
Yeah, my name is Anita Mganga. I'm student midwife from Aga Khan University, pursuing Bachelor of Midwifery. Sina swali, lakini napenda kumpongeza sana Janet kwa ujasiri na jinsi ambavyo unaweza kufanya kazi yako vizuri ya kuelimisha vijana wengine. Binafsi nakupa maua yako. Lakini pia ninakusihi uendelee kuwa balozi mzuri kwa vijana wengine katika jamii, ya kwamba kuishi na maambukizi ya virusi vya ukimwi sio mwisho wa maisha, na bado ndoto zao za kielimu, za kimaisha zinaweza kuendelea kufanyika kama ambavyo wewe unaishi maisha yako kwa furaha huku unajijua hali yako ya afya pia.
Thank you very much. Yes.
Thank you. My name is Alfred Jubilate. I'm a medical student at Muhimbili University. My question is to Dr. Kayange. I see you are the country director of Walter Reed Army Institute of Research. So I would like to know, is there like opportunities for youth who are passionate in research activities, that maybe you are running these surveys where you think youth can chip in and can benefit from those research? Thank you.
Thank you very much. Let's talk on the last question. Karibu, over there. Okay. We have the 4th and the 5th ones. Karibu.
Thank you. My name is Rose Mpembeni from Muhimbili University. May I congratulate the panelists for dreams. You are doing a good job. However, to control for HIV, you need to have multiple ways of doing it. I was involved in one study where they were studying, they called it prevention among the positives. That is, people who are HIV positive are also empowered on how not to infect those who are negative. So what does DREAMS do for those who are already infected with HIV to ensure that they are not transmitting the infection to our adolescents and youth girls who are now almost a vulnerable population? Thank you.
Thank you very much. The 4th and 5th questions.
Good afternoon.
Afternoon.
Dr. Anosisia Kesale. I'm a country lead for the USAID LHSS project. We are doing career progression for the CHW. Maybe my interest would be, we know that the government is thinking of introducing this community health workers to provide these basic curative services. Now I wanted to know, maybe from that Janet, ningependa kujua mnafanya kazi vipi na CHW kwenye kuwa identify au kuwasaidia vijana kwenye upimaji labda na ufuatiliaji wa matumizi ya dawa, na hasa kwenye self testing, wao wanafanya kazi gani CHW? kwa maana wanaanza wapi na wanaishia wapi mpaka mtu anajipima. Asante.
Thank you very much. Mike, to the last question.
Hello, I'm Dr. Ibrahim, Regional Medical Officer Rukwa. Swali langu ni kwa Janet. Kwanza nikushukuru sana Janet, the way ulivyo na confidence na unaonyesha nini unakijua na kukifanya. Lakini kuna message ambayo ametupa ya hizi false negative. Kwa sababu tunafahamu kule mtaani, maki sisi tunakaa na watu kule, hakuna majibu watu wanapenda kama hizi false negative. Yaani mtu ni positive alafu akawa negative. Na yakiwa hivyo yana soko sana mtaani. Nafikiri mnanielewa yani wale watu wakiwa na hizo negative wanakuwa na soko sana. Sasa hii message isiishie hapa. Kuna kama watu wa wizara wapo, wataalamu wetu wapo, waichukue wakaifanyie kazi. Otherwise tunaweza kupata matatizo makubwa sana huko tunakoenda. Asanteni.
Asante sana Dr. Ibrahim. So let's go ahead and have responses. Naomba Mike huku mbele. Tulianza na kupokea maua kwa Janet. Naamini umeyapokea, and Dr. Kayange, karibu.
Yeah, thank you so much. You said Alfred, right? Alfred, thank you so much for a very nice question. And I think one thing I can say, there's a lot I can talk about what RARE is. So Walter Reed Army Institute of Research. Probably, maybe even after this meeting, maybe we might talk. Maybe I can also give more details of what we are doing. But just in a nutshell, this is a PEPFAR agency. It's one of 4 PEPFAR agencies working in this country. Other agencies, we all know CDC, USAID, as well as Peace Corps. RARE is one of that agency. So it works in Southern Highlands together with HJFMRI, so entirely on the comprehensive HIV programming as well as research. So I think on the research part which you asked, probably I might need to talk to you maybe immediate after this meeting. Maybe one quick just addition from what we have been discussing here. I think I just also to emphasize on having an intentional, to be intentional, making sure that young people are on board. Young people are included in whatever decision that we put up front. And engaging them in planning, engaging them in, in coming up with these innovative strategies. You mentioned, Dr. Afke, that nothing for us without us. I think this is something that we as a program, I think it's very imperative that we take that into consideration. And my underlining sentence here is, let us be intentional, because if we are not intentional, that will never happen. So for whoever that were in this room, from all levels that you are coming, I think we should have another eye to look at young people as we go and approach the epidemic control, making sure that we close the gap by 2030. Thank you.
Yes, asante sana. Karibu Janet. Unafanyaje kazi na CHW kwenye kuwabaini kwenye mambo ya upimaji, lakini pia kwenye HIV self test?
Asante. CHW ni wahudumu wa afya ngazi ya jamii. Hao mara nyingi huwa tunakuwa nao vituoni, kwa sababu sisi kazi zetu tunafanya na watu wa vituo vya afya. Kwa hiyo hata sisi au CHW tunakuwa nao vituo vya afya, yani tunasema ni wahudumu wa afya ngazi ya jamii.
Okay, asante sana. So there was another question from Dr. Rose Pembeni. Karibu Dr. Prosper.
Thank you very much. I'll respond to both the prevention for positives. Thank you, Dr. Pembeni. I think one of the findings from that study was instrumental in shaping the policies that we have adopted. Tanzania is implementing test and start as one of the policies, and this is rooted from the experience that came from the start that you were involved, but also the start trial. But within the program, the DREAMS program, the biomedical and behavioral interventions also include messaging on U equals to U, undetectable equals untransmissible, and with the aim of two two impacts. One is to reduce stigma and de-escalate HIV paradigm, because in the past it was associated with disability, debilitation, and death. But two, to empower those living with HIV and also the community to be confident that those who live with HIV, if they have undetectable viremia, then they cannot transmit the disease. So I would say that's it, and I think we can have further conversation on this. On the issue of community health care workers, do we have any community health care worker in this audience? Because usually it is important that we have a lived experience from CHW. But if we don't, there are two issues that I'd like to highlight here. One is we have community health care workers who are not yet formalized. And these are the ones that we have been collaborating and working with in the HIV response. And of course, their role includes mobilizing communities, but also tracing of contacts and index testing. Their role are not allowed for HIV testing, but they do it in conjunction with those who have been certified to provide testing. However, the government is reinvigorating the community health care workers program. And currently, the program for training, including curricular development, is completed. The planning is completed. And we think that, we believe that the first batch will be coming out at the end of this year. So this is an area that we want to work and collaborate with all partners to bring again this workforce, because we know that within the mainstream health systems, we still have a challenge of HRH. And as the service now is more structured around prevention, there is a significant role that CHW will need to play. And therefore, it's my call to the audience and other partners to join hands with the government and other stakeholders to revive and revitalize the CHW program. Thank you.
Thank you very much, Dr. Prosper. I think we've had all responses to all questions. And the other issue was just a takeaway message that was provided by Dr. Ibra to Janet and the rest of us about the false negatives. So 10 minutes ago, I was flagged by the secretariats that I only had 5 minutes. That was 10 minutes ago. So we're way beyond time. I would like to take this opportunity to really thank the speakers. A round of applause for them. And a round of applause for you as well. So thank you very much for participating in our forum. This marks the end of our discussion today, and hope to see you next time. Jamhuri ya Muungano wa Tanzania. All right, let's try that in English. United Republic of Tanzania. That's your homework. Asanteni sana.